Greetings, everyone. You're all welcome to this webinar session, which has been part of our long-standing webinar series from last year. This is the AFRH, the Association for the Fertility and Reproductive Health. We are a meeting of experts when it comes to the assisted reproductive techniques. We compose of doctors, embryologists, nurses, and other allied professions that assist us in achieving a healthy pregnancy in women. Essentially, this is going to be one of our clinical presentations, and is going to be handled by one of our senior teachers and scholars, which I'm going to be introducing in a bit. But before then, I'm going to introduce my co-presenter, who is by name Mrs. Inipi, who will be telling us some things about the upcoming conference, lay some ground rules for us, and then after that, I will introduce the speaker. So I will hand over to Mrs. Inipi now to introduce herself and then take it up from here. Thank you very much.
Good afternoon, everyone. As usual, I'm always here to appreciate everyone for joining our bi-monthly webinar series. And I believe very well we're in for something big today with Dr. Akintola. So before I move on to my announcement, a big thank you to everyone that has registered so far. And as we all know, early code has been early, let me use that word. Anyway, the second Congress of the African Federation of Fertility Society, AFFS, and the 16th Association for Fertility and Reproductive Health, AFRH, the annual international conference, which is the 16th, tagged AFFS Abuja 2026, is coming up, and it is scheduled to take place on the 24th to 26th of 2026. The theme is Fertility Frontiers, Global Innovation, and Advances in Human Reproduction. The venue is Abuja Continental Hotel, FCT Abuja, Nigeria. Now we'll kindly go through the flyer for more details, which is also posted on the AFRH platform. All our participants, we are all encouraged to register for this conference via the website www.affsconference2026.org. Like I rightly said, the early bird code has stopped. It stopped on the 21st of June, and late registration is ongoing right now. The details for the late registration is on the flyer. This late registration will last till mid-September, after which registration closes. So we please admonish everyone to please register if you have not registered. An abstract submission for the conference is ongoing with 7 more days to go. Please don't miss this golden opportunity to present your research and contribute to the advancement of fertility care across Africa. There are exciting prizes to be won: best abstract submission, and of course, the cash prize is 100,000 naira for the best embryology abstract submission, courtesy of Mrs. Bobo Kayode Memorial Foundation. Then, of course, a cash or 100,000 for best clinical oral abstract presentation, courtesy of the conference LOC team. The format and submission guidelines for this very abstract, kindly visit the AFFSconference2026.org/abstract/ash, and you'll be guided appropriately on how to submit the abstract. Additionally, we encourage everyone to download the AFRH Nigeria app. There's no need to visit the App Store. Kindly install it through the link on the flyer. Maybe visit the app.afrhnigeria.org/install. With that, you can install AFRH Nigeria app on your devices. Please note that everything that will be mentioned today, the presentation so far, it will be recorded and be available for playback on our AFRH website. Kindly follow AFRH on all our social media handles as displayed on the screen for updates and announcements. Please do not forget to drop your questions in the Q&A chat box, and it will be addressed. Over to you, Dr. John. Thank you.
All right. Thank you so much, Mrs. Inipi, for that talk. Well, we truly appreciate that. Next is for us to introduce our speaker who will be taking today's webinar topic having to do with assisted reproductive technologies, updates and advances. I have the singular privilege to introduce a very senior gynecologist and fertility expert in the country. He is by name Dr. Lateef Adekunle Akinola, who graduated from the University of Ibadan in 1985 with MBBS. Since then, he has trained in Nigeria and abroad to earn the MSc in Human Anatomy / Embryology from the University of Lagos, PhD in Molecular Reproductive Endocrinology from the University of Oulu, Finland, where through his research, he cloned the gene responsible for estrogen metabolism in human and research animals. He is a fellow of the Royal College of Obstetricians of Gynecologists, England, and the fellow of Royal College of Obstetricians and Gynecologists. He also got an MBA in Human Health Services Management from the University of Plymouth, England, to sharpen his health services management skills. Dr. Lateef Akinola is a distinguished obstetrician and gynecologist, reproductive medicine specialist. He's a tutor of tutors and an undergraduate and postgraduate teacher in various hospitals, home and abroad. He's an adjunct associate senior lecturer and seasoned senior research fellow at the Department of Obstetrics and Gynecology, College of Medicine, University of Lagos, Nigeria, and a senior research fellow at the Center for Clinical Trials, Research and Implementation Science, University of Lagos, Nigeria. He trained in the London Deanery and has worked as a trainee and consultant and at St. Bartholomew's Assisted Conception Unit, Royal London Hospital, Newham University Hospital, Luton, and Dunstable Hospital. The Poundbury Fertility Clinic and the London Women's Clinic. While working in these hospitals, he gained advanced specialist interests in obstetrics, gynecology, minimal access surgery, which includes laparoscopy and hysteroscopy, and fertility medicine. He has a keen interest in molecular biomedical research, especially in ovarian steroidogenesis and folliculogenesis, as it pertains to assisted reproductive technologies. His clinical research interests also encompass endometriosis, adenomyosis spectrum, recurrent miscarriages, fertility optimization, and polyendocrine metabolic ovarian syndrome, previously known as PCOS, and high-risk obstetrics. He has published extensively clinical research interests in high-impact journals. He is happily married with children. He presently practices in Lagos as a consultant obstetrician and gynecologist, reproductive medicine IVF specialist at the Medicine Specialist Women's Hospital, Lekki, Lagos. He's a member of the Executive Council and Editor-in-Chief for SOGON, Lagos Sector, and AFRH. He's also a member of the British Fertility Society, European Society for Human Reproduction and Embryology, and the American Society for Reproductive Medicine. We'll stop at this point. It gives me great pleasure to welcome our distinguished teacher, Dr. Lateef Akinola, with a digital clap from all of us. And I'll be handing over to him to take over the stage for presentation. You're welcome, sir.
Yes, thank you so much, John, for that encomiums. Good afternoon, everyone. Going straight to the webinar for today, let me quickly share my slides. Let's see. Okay, so I hope we can all see the slides, please. Okay, so Today we are talking about ART in 2026. What is the state of practice? This is very germane nowadays when we have artificial intelligence and omics. Last webinar, last week, we talked about omics and its fundamental paradigm shift. It brought on to ART practice. Today, let's have a look at the overview. We're going to talk about, mention briefly about the global ART burden, what omics contributes to IVF, and we will touch on the ESHRI 2025-26 guidance, and we'll have a look at multi-omics and AI convergence. What this combination of powerful technological development is bringing to ART. We also talk about, we have this leverage in terms of live birth rates from multi-omics and AI convergence and other allied, very highly research-worthy endeavors around the world. What are the socio-ethical impacts that this is bringing into reality when we practice ART? We also, give a brief overview of the ethical imperatives of the ART precision drive. I have nothing to declare. The global burden of ART, what are the compounding attrition risk of undergoing IVF? We all know that 17.5% of adults globally are infertile, 1 in 6 couples. Worldwide, we have more than 3 million ART cycles performed annually. Yet, the average live birth rate rarely exceeds 35%, and it declines sharply with maternal age. This is also compounded by additional environmental and lifestyle inhibitions, which are very, very common nowadays. This above humbling reality demands molecular precision more than the current algorithmic and morphological assessment we practice. So, what are the status quo of IVF and its limits as it's obtained now? We are mostly using population-based protocols, generalized algorithms, which may not be suitable for every individual. And then we also have limited, knowledge and practice of hormonal parameters and assessments. Our subjective visual grading, seminal fluid analysis, embryo selection methods, which depends mostly on morphological assessments, is marred with, unquantifiable errors that can affect live birth rates. We are also making this practice, our old practice, makes minimal access reproductive technologies, makes ART expensive, repetitive, and of course, emotionally draining for patients and the physicians as well. So we know about what happens during the natural cycle of women, and this is what we basically replicate when we are planning our IVF cycles. IVF cycles have its limitations as well. We know that at the beginning of the cycle, we do all the investigations, AMH, and all the hormonal profile scans and everything. If all works well for the woman, we are going to start on injectables, gonadotrophin injections, whether you are using antagonist or agonist protocol. The goal of this is to get more eggs, more oocytes, after during the time of egg collection. So we need more oocytes, and the more oocytes we can generate, the higher the risk, the higher the opportunity to have a live birth rate take-home baby. So we have been using this unbridled agonist cycle primed IVF protocol in the past, and there are inherent risks in using our agonist cycles, gonadotrophin plus buserelin initiated cycles. Of course, we know that using these cycles as we use now, one size fits all, increases the risk of OHSS, especially in our high responders. And with this, we have, high proportion of canceled cycles due to this methodology we are using. There has been some, discussion this while about agonist or antagonist cycles and which one is appropriate for each and every individual that comes for IVF treatment. We know about total gonadotrophin dosage, treatment time, risk of OHSS, total cost of medication, and then we know which one of them is user-friendly and which one of them have higher rate of cycle cancellation. It's been proven, while that there is no deleterious impacts of GnRHA antagonists on oocytes, embryo quality, compared with those treated with agonists. And this is highly recommended by the latest ESHRE controlled ovarian stimulation guidance in 2026. And this basically tells us that the advisable thing that we'll do for low responders, normal responders and high responders are listed. And it is basically the amount of gonadotrophin we use based on the AMH and AFC algorithm that we are used to. But this has been, studied very hardly. The guidelines committee of ESHRE, they've come up with a brilliant proposition, which they've made, a few years back, and they are reiterating now in 2026, that for low responders, you can basically use any of the antagonist or agonist protocols. However, when you come to normal responders, you have the liberty to consider which of these treatment protocols you are going to use. But they basically recommend that we should focus on the first choice, that is gonadotrophin releasing hormone antagonist protocol. Also, for those who are high responders, the agonist protocol is not recommended because of its high risk of ovarian hyperstimulation syndrome and cycle cancellation. So they also favored significantly GnRH antagonist protocol. And of course, when it comes to what to do about the trigger, when you are supposed to do the trigger, they recommend ultrasound monitoring, follicle size and number, which we have been using. And then if you have the chance, you can complement with this hormonal profile, estradiol. You can judge that against endometrial thickness. And then you can come up with a conclusion that will give you at least an approximate window of implantation that that has been proven research-wise that is effective. The effective range of endometrial thickness has been over 7 millimeters in endometrial thickness measurements. They also talked about, the recent guideline also talked about oncology fertility preservation, cryopreservation, the ones we call social elective oocyte cryopreservation, and of course, oocyte donation. They are recommending here that you can equally decide which of the cycles you want to use, but you need to, depend on what pathology you are trying to conserve conserve fertility potential for. If it's oncology fertility, you can start at any time of the cycle, and it's advisable for you to use what they prescribe. We can see, let me see if I can show that. We can see here, they said gonadotrophin antagonist protocol is the most likely that they suggest that we should be using. They give a range of dosage of gonadotrophins, and you can also consider, in some cases, using letrozole and tamoxifen. If it is elective oocyte cryopreservation, the SY called social social egg freezing for those who wants to preserve their potential for fertility at any time, until they are ready. Then we are also advised to use, we can choose between gonadotrophin antagonist protocol and progestin as well. This is, highly outlined in the recent S3 guidelines, which is, copied here. You can reference it and search on the internet for more details. Now, the system we have now in 2026, there is a lot that has changed. And we are gradually, and in fact, I would say we are moving fast from algorithm-based ART treatment to precision and personalization of ART treatment protocols. And we have a lot of confidence in ART, and that ART does not, make ART offsprings, deficient in terms of congenital anomalies, long-term, neurodevelopmental achievements, and it doesn't increase any more than natural, all the imprinting epigenetic diseases. And this has been now supported, and it has been proven by recent thesis findings from Karolinska Institute by Mujin Ye, which complements all the earlier research findings that ART is safe and it does not, move all the children delivered by ART into some congenital problems, whether during the neonatal, childhood, or even adulthood. And this we have witnessed all around. Otherwise, nobody will be practicing ART if that's the case. And this has given us the impetus to further the research and apply the research findings we are having now in the ART world, given that there is no deleterious effect of ART on the overall development, whether in the neonates or baby or childhood or even in adulthood, for those who are delivered by ART, that is more and more than what is obtainable in the real world. Now, we are refining algorithm-based ART personalization. So we can see now that there are three ways that this is being tackled. We have the endometrial optimization, especially we are now doing a lot more of FET, because right now we have the protocols, the guidance to get more oocytes during our OPUs. And then it comes to the time to decide whether we're, for our FET, frozen embryo transfer, are we going to use medicated or versus natural? And recent research has also concluded that it may be worthwhile, to focus on a natural cycle. The recent research also said medical, non-medicated cycle FET program, luteal phase support, or day 6 or day 7 FET did not significantly improve the live birth rate. And in fact, people are now, basing it on more and more on natural cycle if there are no other compounding diseases from the women. They are now using natural cycles that have proven corpus luteum demonstrated on ultrasound scan. So instead of using all these medication to prime the endometrium, we can basically rely, if you can find a very nice picture or a very nice demonstration that your patients have got during the natural cycle, there is a well-developed corpus luteum, you can actually use this. And this has, given us the guarantee that possibly pregnancy rate during using natural cycles might be much more beneficial than using very expensive medically primed endometrium. And then it also shows us that refined progestin prime control ovarian stimulations is now becoming in vogue. And this is also one of the items that that's been proven to work well, especially in those who are at very high risk of OHSS when you use the natural gonadotrophins in excess. So we also have, recently we know that PCOS has been changed to polyendocrine metabolic ovarian syndrome. And recent research are now focusing on the racial and ethnicity-based PCOS profiles. We know that in Blacks and Hispanics, AMH levels are very low, and then we have more of the metabolic diseases. Likewise, in India, AMH is lower than what we have in the white women, but our own is that we have a lot more of metabolic syndromes, diabetes, hypertension, fibroids, and all the other pathologies that we can mention about. And using AI models, it is possible to personalize and individualize treatments nowadays, or PMOS. And this has given us significant OHS prevention. And there's a lot of research still going on how to prevent OHSS happening at all if you follow AI-guided models during your stimulation protocols. There's also a rapidly developing research and development systems for biotoxicological safety and success checks before real-world application. That means that there's a biological system that is called microphysiological systems that can be used in the research realm to predict human reproduction prowess, where you have human gametes development. We have this is what is called organ on a chip. We have this biosystem that mimic gamete development, mimic fertilization, mimic implantation, and mimic maternal-fetal interactions. We can use this system to study our newer protocols. We can use this system to see how our newer protocols, AI prime protocols or AI suggested models, to see how they will react in research modes before we bring them into reality. This is gaining more and more of usage, and is bringing us more into the precision era that we like. And the advantage of using this system is that you study your protocol at the research bench before you start to apply it to the patient, to reduce risk and guarantee a lot of safety for your patients, either from the drug or from the psychological trauma that will follow if there's any failed cycle or any complications during the process. So the other area that is being looked at now is targeted interventions to rescue failed IVF cycles. That we have cumulus-mediated. One of them is cumulus-mediated sperm selection. Instead of using our artificial, system to decide, or morphological system, having a look at the sperm or doing the DNA fragmentation index, we can actually use cumulus to select the best of the sperm that we can use for fertilization of the oocytes. And this is also gaining more and more priority as a way to improve live birth rates and pregnancy rate as well. So there's also another system that is advanced assisted oocyte activation using calcium ionophore. This has been on since early 20s or middle 20s, and it's been now resuscitated and refined to make it much more applicable in this AI era. So There is one that is also of particular interest, mitotic arrest analysis. This research system will improve our understanding of early embryo arrest, informing us about newer media, culture system, and then we can use this along with time-lapse and AI multiomics convergence. We can use it to determine the best embryo to implant, to transfer, and the best reaction we can get if we do the research very well before we start to apply it in the real world. This will significantly reduce cost of IVF, making it available for almost anyone that seeks IVF. Epigenetic profiling is also one of the things that are coming on board, and it is now using epigenetic sperm profiling. They can use that to determine which of the sperm that we are going to use for ICSI have got these genes. These genes have been associated with significant improvement in fertilization rates, embryo quality, and then resulting in better outcome after IVF treatment. So this is a research that is developing, and hopefully in the near future we can join the research band. We cannot but forget to talk about AI in IVF laboratory automation. See what our embryologists do at work. Wow, they may not even have time to drink coffee. They are the one that documents KPI and statistics, sperm preparation, warming the oocytes or embryos, trophectoderm biopsy, updating patients and counseling, crowd preservation, embryo transfer, QC and QA, oocyte retrieval. This is a lot of job. They hardly have time to rest. But now we are, at the AI era, where we can have our laboratory processes automated. So giving our embryologists more time to supervise and, of course, to drink cup of coffees along the line, where robots are doing most of the job, and most of them are very, very much autonomous. The impacts are enormous: increased lab efficiency, reduced human error, more consistent and reliable results we are going to get from our AI robots, and then it prevents embryologists burnout. I'm sure our embryologists will, weigh very strongly in support of IVF laboratory automation. There is also a significant shift towards reproductive omics, molecular precision era. We talked about this, last time. There's this significant shift from reproductive omics to reproductive omics, from morphologically based assessments and grading of embryos and sperm. Currently, we are mostly using subjective assessments, which is, not the best. A significant error, either interpersonal or intrapersonal errors are possible. Morphological grading is prone also with errors. Visual trial and error. Structural observations may be wrong most of the time if they are humans are, error prone. And of course, all these are based on empirical algorithm handed down by our IVF forefathers. Now we are moving into the precision era, predictive medical era, where objective measurements are what is being advocated for. Multi-layered analysis that is beyond human comprehension. Internal molecular architectural studies look at the cell as a whole, and then you can see all the architectural buildups of the cell organelles, how they are structured, how they interact with each other, and this, give us a very, very high predictive intervention and leading us to personalized medical approaches. What omics contributes to IVF are enormous. Of course, we know about genomics, transcriptomics, proteomics, metabolomics, epigenomics. There are a lot of omics that are also coming on board. So Advanced genomic examining, that is examining structural and epigenetic aberrations to uncover root cause analysis of unexplained infertility. We know that using optical genome mapping and high resolution technique, we can visualize ultra-long DNA molecules to detect any structural variants across the human genome with unqualified, unprecedented accuracy. We can see how many copy numbers are in the genome, balance, whether the genome's balance or unbalanced. We can map out deletions, duplications, translocations, aneuploidies, and etc. So compared to the time when we use fish arrays and karyotyping, this has significantly revolutionized, genetic-based analysis of fertility failures. And of course, we also know about male factor evaluation that is now including sperm epigenetic biomarkers. You can tag sperm with special biomarkers, antibodies, to see which of them are much more reliable, much more have fertility potential that will increase your generation of quality embryos to transfer. This we can use in assessing DNA mismanagement, misarrangement, and of course, it's also another bit that we can combine with DNA fragmentation index to get the best of the sperm. These are currently very expensive moves, but hopefully with time, with more R&D on the system, with more price reduction, it can be very available to everybody worldwide. Multi-omics and AI convergence, we talked about this last week, and then we are talking about inputting omics data sets into time-lapse morphokinetics, patient clinical history, putting all this data into machine learning integration, artificial intelligence machine that will give us a predictive embryo ranking, a sample IDA score. We can use this score to rank our embryo instead of using the popular morphological assessment. But this is still, might be an expensive process to go through. Multi-omics data sets, we can get that if we want. Time lapse is still maybe a little expensive. Patient history, we have it. And if we combine all this data and feed it into our, MLL integrated machines, we can have, we can substitute this with omics score, IDA score, giving us our best embryo to be selected for transfer. The synergy between artificial intelligence and omics has given us a redefined ART-IVF treatment pathways. We talked about all the traditional errors that we make in our traditional IVF treatment profiles, and we're now in the era of predictive modeling, AI and omics combination, systems biology, real-time learning, individualized patient treatment, and of course, lifetime reproductive optimization. So we are moving from reactive protocols until you start your cycle, then you start, seeing that patient is not responding, you cancel the cycle. But now, before you even start your treatment, IVF treatment cycle, you already know what the patient is going to, how the patient is going to behave along the line. So you will have prepared for it. And this is where the predictive precision mechanism stands a lot better than the one we are using now. Hopefully, this is going to be a available common practice around the world. We've talked about embryo selection, from the static morphological assessment that we are using now with all the predictive inaccuracy, which is also snapshot in a time. We are now moving on to next generation selection using all the data we have available, transcriptomic, metalloBone, spent media analysis of omics, time lapse, PGTA integrity. All this can be give us a robust assessment of embryos before we even implant it. And we'll be rest assured that doing all this, getting all these IDA scores, getting the best embryo using AI and omics combined can give us a better assessment of embryo to be selected. And this can also, help us moving from the multi-embryo transfer that we are currently doing, 3 or 4 or 5, some centers put as much as 5 embryos during their transfer. We are moving very, very rapidly towards elective single embryo transfer using all these combinations of omic and AI and morphokinetic analysis. AI and genomics we can use to predict all findings, especially when we have low response patients for IVF, those who are above 35, close to maybe close to 40 or above, where genomic variants are much more variable, even in the younger ones, FSH, LH, E2, progesterone receptors polymorphism. So we can use AI and genomics, buffered genomics analysis to identify this this individual with gonadotrophin polymorphism, and combined with their baseline hormonal profile, historical cycle response, we can use this to predict who among these will have empty follicle syndrome, rather than discovering this on the day of egg collection. And then we start running Lexascatter, doing HCG, giving her another HCG, postponing for that collection till the next day. This AI genomic combination will revolutionize that. So even before we start the IVF treatment, we're already going to know how this patient is going to behave. We already have that inbuilt knowledge that, look, we have studied this patient's genomics, and we've seen a lot of these variants. So we have to be prepared with for the treatment. Either we are going to increase our cycle, our gonadotrophin dosage, or we are going to, modify our trigger system, or we are going to give her other adjuvants that can help her to at least make it possible for us to collect eggs when we do we treat these patients. We are still in the era in in the reproductive recurrent implantation failure by doing transcriptomic profiling of endometrial biopsies. And then there we can see a lot of mRNA endogenous gene expression, hormonal dynamics, combining with historical cycle response to calculate the specific identifiable window of implantation. And we can use this, for most of our patients that can afford it. It's still an expensive process now. Hopefully, it will also become cheaper in the next few years. We can use it to identify precise time window of implantation to, do our embryo transfer. Also to increase live birth rates, shorten the time between treatments, the time between infertility and live birth rates, take-home baby time. So this is very good, advisable to use it, but most centers aren't using it, likely because of the expense. We hope it's going to be a lot cheaper in the near future. The long-term vision of all of this is to do continuous updated AI or mixed modeling of the patient. We model the patient in the lab. You have your patients where we know what our genomic profile is. We have studied our transcriptomics. We've done a lot of research on the patient about proteomics, metabolomics. We have the patient's historical data. We know the patient's fertility journey. And then using our own clinical acumen, which is not negotiable, then we can use this to produce a proxy stimulation ART strategies before we start these treatments. And these applications are optimized treatment cycles and pregnancy, for healthy babies. That's where we are moving in the future. And of course, there are very, very emerging, interesting technological developments on the horizon, using the single cell multiomics, where you have a single cell that is being studied round the clock, multiomics, genomics, transcriptomics, metabolomics from the same cell. And then you can see DNA or chromosomal array and modifications along the line in the individual cells. This will help us to, guide us as to get the full knowledge of how the cells is going to behave in vitro. In vivo, before we even start our treatment. We know about cell-free spent media analysis that is gaining acceptance. Some of our IVF clinics are already using this system, and so far I don't see any of them complaining of irregularity of results or dependency on the results. We are beset with all these technological developments. In 2026, we are beset with a lot of ethical implications and complications to consider. We are going to go through this. Now, we know recently that there are a lot of talk about embryo status, especially in Alabama, USA, when they first, move from the fact that embryo are just cells, they are not human. And the legislators there, they are saying, look, embryos are mini-human, and if you destroy them, you can be charged with homicide. That is, you are killing an infant. So, and this is what is shown. What has been extremely debated in US, but now there are agreements that we have to develop, we have to consider a lot of ethical issues along the line as we are bringing all these omics, artificial intelligence, precision medicine, genomics, transcriptomics into the system. Are these ethically supportable? Are they something we can use without risk to the current human population or the future sets of humans that will inherit the earth from us? What are the ethical issues to consider? Should we be storing embryos for more than 10 years or gametes? AI embryo training models, genomic R&D, embryo-derived models, organelles, somatic gene therapy, embryo editing for research and development, and recently germline editing, base editing, or CRISPR. This needs a lot of regulatory stance before we misstep, and that can lead us to unsavory or place where we don't want the human race. So there needs to be a strong training oversight and monitoring of all these research protocols. We also need ethical guidelines, global assets, global moratorium, especially on this base editing that is still at research level, and some are even contemplating taking it out into private establishments to make more money. We shouldn't be rejecting all these developments, technological developments outright. We should study them very well to figure out which are the unknown epigenetic risks. We should work out to prevent lack of diligent consenting and counseling. Of course, manage the societal divisions that we're going to encounter. And of course, there will also be a lot of religious backlash as to the genuity and why humans should be, editing germlines, already built by God. There are organizations that are looking into this very specially. WHO, for example, US FDA, Food and Drug Agents, and UNESCO, and all other countries and interested organizations are looking into this, how we can prevent all these ethical red lines. For example, in polygenic embryo selection, there are people now trying to study how all the genes interact. Can we categorically say in 2026 that we know how all the genes in the human body behave? We don't know, most especially when there are epigenetic connotations in all these genetic dispositions. So we can see that there are benefits in all these polygenic embryo selection, PGT, polygenic for therapeutic disease prevention, which is highly encouraged, versus genetic alterations for traits, enhancements, the so-called designer babies, height, intelligence. This should be strictly discouraged to avoid child objectification and, of course, genetic inequality. We have some labs saying, oh, I have this person 100% IQ that is more intelligent than the other race. Is going to lead to a lot of genetic inequality and discontentment in the society. This should be very highly discouraged. They are good, research progress, but there are ethical red lines that our government and other notable organizations should come out with a strict guidelines, strict red line zones. Nobody should go beyond this red line. We are moving from assured capability to rigorous oversight now, rigorous ethical oversight. In the past, we do a lot of unregulated biotech R&D, trial and error, clinical success, guaranteed or not. But at the present time, genomic precision medicine is taking over. But these are beset, as I mentioned earlier, with a lot of bioethical concerns. Social, religious, economic, and societal. There should be a recommended global law, AI governance, that guides all our processes, especially when it comes to AI and omics convergence. All the ethical issues should be trashed out before we move into it. Genetic errors should be studied and how to avoid it. Either we don't go that way, or there are things we can modify to prevent all these genetic errors. Of course, most of this, or at least some of these, are guaranteed to lead to, fatal significance. In the system now, we have a lot of absence, especially ART systemic governance. We lack statutory oversight. Clinical frameworks are not well defined, and these are rapidly coming into public integration without, adequate studies. We should pause here and, in order for us to reap the benefits of advanced ART technologies, we should stop exploiting vulnerable populations, especially our stakeholders who are, tired of their infertility, and they can do anything to have a baby to take home at the end of their treatment. So organizations around the world, ethical organizations, ethics societies are working around the clock to make sure that humans don't misstep and we don't create a problem while we think we are trying to solve a problem. Yes, we have the system about medical techs, but the socio-ethical imperatives are also of importance. Transparency, we need transparency in our AI applications to avoid the black box scenarios. We need strict avoidance of racial or genetic biases when we're studying all this or we're applying all the AI-enabled machines. Data privacy and equity should be guaranteed. Rigorous clinical validation before real-world applications should also be guaranteed in our ethical guidelines to avoid fatal mistakes along the line. We don't input genetic errors in the human genome that will be transmitted for generations to come, and that may not be so easy to correct. We also need to make sure that our CRISPR-based editing designer babies syndrome are quashed before even starting. So there are a lot of organizations working, as I said, around the clock to make sure this is not going to happen. human fertilization and embryo technology. AFRH is also doing its bit. Swedish National Council on the Medical Ethics. Queensland in Australia, they are working also. FDA is also doing to make sure we have a perfect guideline, especially on cross-border ART, surrogacy, donor policy, posthumous conception, three-parent IVF, CRISPR, baseline editing, AI multiomics, and autonomous IVF lab assembles. So we should be very careful, make sure we are following ethical guidelines that will not put us into jeopardy or put the human race into jeopardy along the line. The future of IVF, take-home babies, genetically normal offsprings are albeit almost guaranteed. Autonomous IVF lab is coming, but we have to be careful, be wary, not to apply this into the real world before we know precisely through our rigorous R&D what the outcome of these applications going to bring to the human race. Thank you for listening. I wait for that questions. These are my references. As Mrs. Inipi said, the second AFSS, is coming soon. Let us all prepare in combination with AFRH, IFSS, and of course, ASRM, and other notable companies like Cooper Surgicals. They are coming to Abuja, and it's going to be a grand conference. We encourage everybody to participate. Thank you for listening.
Thank you so much, sir, for that lucid presentation. I'm sure we're all coming into contact with some new terms and new concepts. This is just to whet our appetites to do further research and continue to build up on what our able teacher has taught us. So I'm sure we are going to have a lot of questions. We already have some here, which I'm going to start with, sir.
Yes.
Yes, we have somebody here asking, please, I need more explanation on cumulus cell-mediated sperm selection. How can I identify cumulus cell-mediated sperm for injection to overcome sperm DNA fragmentation problem?
Well, as I mentioned earlier, these are research studies coming on to real-world application. I mean, when you do your OPU, when we do all these OPU, we have a lot of cells in the follicular fluid, and these cells can be identified by specific genomic signatures of each cells. And then you can harvest cumulus cells, you can harvest granulosa cells out of the follicular fluid, and you can use this in systemic biological research models. These are models; they are not commonly applicable now. They are still in the research variant, on the research table. So you can get the cumulus cells out of the follicular fluid, and then you can, do experimental findings on your sperm fluid. It's more or less like this setting. I've forgotten. I'll remember. I'll tell you when I remember in a minute. That where you use we use fluidic system to separate sperm that are potentially fertile with good fertility potential from those that are not. So this is going to also come into being, and is what is happening now in real research world, and of course in laboratories that can afford such research models. And what they are doing is, instead of doing the morphological assessment of sperm, even it's going to replace the DNA fragmentation index, which is very variable around the world from company to company. You get different results, and it's not all applicable to all patients. So we can use this system. It's coming on. It's not available right away, but it's a research project that we can follow. We can identify cumulus cells easily by their genetic biomarkers, and you can use this to select sperm analysis. We can guess you get cumulus cells, you put them on your dish, and you apply you put sperm one side, and you see the ones that will swim past these cumulus cells, and you can use those to do your fertilization.
Thank you so much, sir. I think that's the only question we have. I don't have any other question on the Q&A and the chat sections of the webinar channel. Should I assume that is all we have? Mrs. Yejide, do you have any other question you are seeing from your end that I'm not seeing?
No question.
All right, so okay. So I think I will hand over to Mrs. Enigbi.
Oh, there's one that is being asked by Barrister Ondiga.
Okay, yes,
saying,
I just saw it here.
So she's asking, where's that question? I saw it just now.
Yes, what are your thoughts about how we can create a better regulatory framework for Nigeria?
Well, we have a lot in Nigeria. The system works very slowly, and I'm sure we are going to get there. You can see even to get a national ART code of practice has taken us a significant number of years, if I may say, even 10 years or more that we have been on it. And we have, even though we are pressing it very hard, we have reached a doldrums now. We are just there. We are not moving forward because it's stuck in the House of Representatives or the Senate. So I think all the organizations responsible, all the stakeholders need to meet again and decide and come about a decision that will benefit our patients. We are doing this to our patients and all our stakeholders. We should have a consensus, and now we can get rid of all the quacks around and be focused on giving our patients the best. How we are going to achieve it is a simple thing, but I don't know why we are finding it so difficult to do. And until we can do it, we have all these problems that we are having now. And you can see, you can hear now that Nigeria is the center of surrogacy around the world when India has closed the door. So hopefully we wake up. I hope we are going to wake up very fast before we start seeing all the complications and all the misdemeanors, surrounding ART that is happening all around the world. I can only say that we have to persevere, try and convince our our legislative to wake up to their responsibility, give us a good code of practice, ART, at least start, and then we can see how we can move forward. Lagos State is in front and has done very well, but even to apply what Lagos State has brought to the ART world around other states is very difficult. It's extremely difficult. We make laws that have no legal teeth backing it up. Until that can be solved, I don't see how we can move forward on this. But the future is bright. Thank you.
All right, thank you so much, sir. We have another question here. Sir, thank you for a wonderful presentation. Please, could you give us a brief explanation of calcium ionophore? I understand it is sometimes used in assisted reproductive technology, but I would appreciate a little more insight into how it works and the situations in which it is used.
Yes, calcium, sometimes when we do seminal fluid analysis, we can diagnose azoospermia, oats, oligoasteroteratospermia, and all these sperm aberrations does not give us consistent fertilization results. And oftentimes when you use it, you have fertilization failures. We have fertilization failures Either there is no fertilization or there is fertilization, but on day 2 and day 3 checkups, we have embryo arrest. And because the ICSI mechanism is failing, there's failure of the sperm to penetrate the oocytes and then fertilize the embryo. So in systems where you have calcium ion ionophores, it makes it possible. It's prime the embryo, the oocytes, makes it easy for the sperm to enter the embryo. Then we can also use this when with I've forgotten, oxyphilin. We can use it with that, plus calcium ionophore, to increase fertilization rate. It makes it easier whether the sperm is motile or not for fertilization to take place, and it supports our ICSI. So when we do it, you fertilize in the media that contain calcium ionophore, you get more consistent oocyte fertilization. But these are chemicals you need to buy. They are not already included in all the media we use at the moment.
All right, thank you so much, sir. I think another question just dropped. What causes low embryonic development despite high fertilization rates after ICSI?
Well, as I've said a number of times, most of the sperm we use for ICSI, we are using mostly morphological assessments, and some of us use DFI as well. But these are not, very, very consistent in terms of errors. There are still errors, inbuilt in all this system. And if the genetic code that make up your sperm or the embryo itself is not robust, is not up to the quantity it's supposed to be, 23X or 23Y, or there's deletions, micro deletions, or unbalanced translocations, which you cannot see morphologically, this will, cause along the line embryo arrest until we can, define a system that will give us better choice of sperm selection for our ICSI system to guide against selecting sperm that already have inbuilt or epigenetic errors that we can't see morphologically. Those are the causes. Either the genetic composition with sperm is not correct, or that of the oocyte is not correct. So you are bound to have incomplete genomic composition, which will make it to fail along the line.
All right, thank you so much, sir. I think that's the last question we have, both on the Q&A and the chat boxes. I want to appreciate you, sir, for this wonderful presentation. We truly appreciate. And I believe you have given us a lot of reading assignments to do and research, so to better grasp the concepts that have been shared. We truly appreciate, sir. And we appreciate everybody for listening and participating actively, for the questions that were asked. And we thank all of you and the organizers of this. I will now hand over to Mrs. Inibi for some announcements, and we take it off from there. Thank you so much, sir.
You're welcome. Thanks.
Yes, sir.
So we sincerely appreciate you for your invaluable expertise and insightful perspective on ART updates and advances. We appreciate you, sir. Thank you. And of course, to everyone that has graciously joined us for this edition of bi-monthly webinar series, we also say a big thank you. As we look ahead, I'm delighted to always remind us of this year's flagship event that is upcoming on the 24th to 26th of September 2026, and it is happening in Abuja Continental Hotel, FCT Abuja. The call for the abstract submission deadline, 7 days to go. So the clock is ticking. So the call for abstract submission deadline is on the 30th of June, this coming Tuesday. Please do well and submit your abstract. Share your research with the Africa's leading minds in fertility and reproductive health based on the 5 key areas of interest. Please do well and submit your abstract. Share your research with the Africa's leading minds in fertility and reproductive health based on the 5 key areas of interest. Please do well and submit your abstract. Share your research with the Africa's leading minds in fertility and reproductive health based
Thank you.
Introduction. Okay, so of course there are prizes to be won, 100,000 naira to be won on site for two best categories, the embryology abstract submission and clinical oral abstract presentation. So anybody can win both. That's 200,000 naira take home. So this is your second chance to showcase your research by submitting your abstract. And of course, submission guidelines and format requirements. Please visit affsconference2026.org/abstract/hash. We also invite you to download the AFRH Nigeria app at visit.app.afrhnigeria.org/install for seamless access to updates and resources. Today's presentation has been recorded and will be available on the AFRH website. So we encourage you to as well follow AFRH on all our social media platforms for the latest announcements. Our next webinar is scheduled for the 8th of July 2026. So we look forward to welcoming you then. Thank you all once again. Over to you, Dr. John.
Thank you so much, Mrs. Inikbi, for those announcements. Quite refreshing. Please want to thank everybody on behalf of the Central ESCOs and the training committee for attending this webinar. And we also thank the presenters, my co-moderator as well, and to everyone for being in attendance, because without you, these webinars would not have been possible. We appreciate all of you, and we hope to see you in the next presentation and eventually during our forthcoming AFFS conference in Abuja in September. Thank you all and have a great day. Thank you.
Thank you.
Bye, everyone.
Bye for now.
All right, thanks.